Hello. So I just got done shadowing a family friend who's actually a psychiatrist at the VA, right in the city where I live at. So yeah, today was my first day doing that, so I didn't get to see a ton. However, it was really cool. So she's an outpatient psychiatrist there, and today she was actually looking at the inpatients. So I got to see her. Um, I got to see her working with them. It was cool because that's kind of what I pictured what a psychiatrist would do. So I showed up. They had a morning meeting where they had social workers, psychologists, nurses, nurse practitioners, fellows, residents, medical students. They had one big meeting with everyone in that department, and I guess they talk about the patients, so you can have insight as to, oh, so and so is ready to be discharged. Hey, insert name here, social worker. Uh, he needs help looking for a program for such and such, etc., etc. So I did miss that. I was kind of disappointed. I thought I was going to get to see that. But it's really cool. So when I did get there, I was able to see her do some follow-ups with the inpatients. So I went with her. We went into this, it's an interview room. So it reminded me of when you go in for your physical appointment for a doctor. You go in that little tiny room after the nurse like takes your height and weighs you and all that. It reminded me of that. So then that was where they did follow up with people that are currently in there for X amount of days, depending on what they have going on. So we had 5 people come in while I was there. It was first off me, the doctor I was shadowing, and then one of the medical students. I want to say he was an M3. He actually played a pretty big role in it, which that alone surprised me. I didn't think third years of all people would really get that much, not necessarily say, but have such an active role. What he was actually able to ask a good amount of questions, and he was actually the one that would inform the attending that I was shadowing. Oh, hey, so and so is about to come in. This was what we got at intake. This is the symptoms he's presenting. This is what he's on. This is his overall diagnosis. So he was actually kind of the one in the know per se. So he was the one actually informing the attending and myself before the patient would come in. So the patient would come in. They would get him from his room or whatever, and I keep saying him because this was at the VA, so most of the veterans are males, especially within the older population. So I didn't see any females, but the first one came in, and it was really interesting. Between the first one that came in and the second one that came in, they both had schizophrenia, but I didn't realize there was a dichotomy to it, I guess, just from what I've had in psychology classes so far. Because I'm a psych major and a Spanish major. No, none of the hard sciences except for the med school prereqs. I was expecting more just like the auditory and visual hallucinations, but there was actually quite a contrast between the two. The first one, he was poorly groomed, just kind of sloppy, was mumbling, like touching his face a lot while he was talking, so it made it really hard to understand him. There were actually points where I had no idea what he was saying. I would hate to be the only one in the room trying to pay attention to everything he was saying, because it got really hard at some points. He did have the auditory hallucinations, typical. Oh, the CIA are following me. I think my neighbors want to threaten me, etc. So that was actually interesting, because I've never actually met anyone with schizophrenia. So it was cool to see what you read in a book versus in real life. But then the second one that came in, the attending and the M3 described the first one as being like a negative schizophrenic, whereas the next one was a positive schizophrenic. In that, compared to the first one, that was kind of like a sloth, like just slow, the just really not that animated at all. Just I don't know. I think I've already described it, but the second one, he was so animated. His hands were shaking. Like he wanted to do things. Um, he actually denied auditory hallucinations, though he kept I don't know. It sounded like he was referring to someone telling him stuff, but he never outright said it. So that was actually interesting that he denied that, because I don't know. It was interesting, just the way he was saying he knew things because someone was telling him, but there weren't voices. So he was really worked up. He kept thinking like people were coming into his room, that people wanted to threaten him. It was more just paranoid and wanting to do something about it. He kept rubbing his head because he was very anxious. I felt really bad. But so that I guess was more the positive schizophrenic, just meaning that he's actually like doing something where it's more like an additive versus negative, which is kind of like taking away. So that was actually really interesting. That right there in a nutshell is everything I just learned about schizophrenia today, because I honestly didn't know that much before now, except, the stereotypes that, oh, they're crazy and they talk to themselves. So it was nice to be able to see that within context. Trying to think, there was a third person. Oh, the third person, he was addicted to a pain medication, and they were talking about different things, like, oh, like, how are you doing, blah 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 blah, when do you think we could get discharged, whatever. He was completely there mentally. He was just a normal human being, just had some trouble with some pain medication, which I guess is actually really common, especially among the veteran population, unfortunately. That's what the M3 told me anyways, when the patient left the room. But nothing too out there with that. I did feel bad for him, though, because being with those other two that I had described, he was the third one out of the 5 on the ward. He likened it to a prison, because I can understand that, because for him, he doesn't really have anyone else that's going through the same thing as him. He's kind of the only one there completely mentally anyways. So I did feel really bad, because the way the ward is actually situated, at least at this hospital, I'm sure it's like this elsewhere, for inpatients anyways, it has 2 doors. So you go through the first door with a badge, so you have to have permission. You go into this little waiting area, but the second door does not open until the other one closes. And then again, you have to re-swipe to then get in through the next set of doors. So I guess that definitely solves the problem of people trying to get out, which was a little scary. I mean, well, I guess because I'm a little claustrophobic myself, I'd be kind of freaked that I was locked in. Maybe that's just me, I don't know. But then the only thing there really is to do is you can walk around the ward. It's actually pretty big. It takes up a good chunk of floor space. There's 2 wings, 2 nurses' stations, because it's big enough for both. So when the doors are all open to all the hallways or whatever, you can go around in a circle and walk. So that was really nice, that it was big enough where you could do that, as opposed to being confined to a tiny room. Yeah, so I did feel bad, because he's just he's a guy, he served his time, he just had some problems with the medication for restless legs, and unfortunately brought him to this, where he's basically locked in this ward with people that aren't cognitively there. He doesn't really feel like he fits in. The hospital food's never the best. He's away from his wife. Like, that must be hard. So I felt bad, but he was getting discharged later today, I think. I don't remember, but it's something like that. So it was really interesting to see that, especially within the VA, you do get people that do have an illness where they can't think right, so you're trying to put them on medications for that. And then you also have just normal people that are just struggling with life. So that I don't know, that part was really interesting to me. But anyways, the rest of the ward was kind of, yeah, bland. They had a day room where you could sit down in plastic chairs. They were really nasty, like with the fake wooden armrest, and then it's just plastic. You could watch TV, but honestly, that's it. Like, you don't have much to do. You don't even have a TV in your own room, so if you go to your room, you're just lying there sleeping. And then within the actual rooms themselves, the beds are nailed down. The chairs are really, really heavy and plastic. The doors don't have doorknobs. It's like a little. It's like if this was a door, the doorknob is like this little thing that just swishes, like it's rounded. Within the actual room, there's not a door other than the one to like get in and out. So within there, like to go to the bathroom, you have a pull-away curtain. So unfortunately, just with the nature of the population and everything, the whole ward was basically designed so you couldn't commit suicide. That was something I really hadn't expected. The beds were really sad looking. It was just a plain light mat with some blankets, but otherwise it was nailed down. It's kind of like a wooden box with a little mattress in it. You have one chair, and then you have a small little bookcase where you can put stuff, but it's not really a place I would want to go if I was in a mental state that was normal. I don't like using that word 'cause, no one's completely normal, but it's not the best environment to stay in long term. But then that kind of gets me to the fourth patient that we saw. His record in the system was so long. There were notes from 5-6 years ago. He's an active crack addict and just needs a place to stay. He knows how to work the system. Oh, he worked it. Went in front of, well, it was myself, the attending, the medical student, and then also a psychologist who was head of the department of like mental health and everything. So she was like way up there. She was the attending supervisor, and she got involved because this guy's been here so many times, but refuses to take medication, refuses to do group activities. So it's at the point where it's like, you don't even want help. You just want it bad, which that's so hard. But it was interesting to see someone like that, because I'm sure that you run into that a lot, especially in the hospital situation where you do have people on the streets that just need a warm bed and some food, but you can't really use that as a reason to come in. So that was really hard to see. Because he got really worked up. He got verbally violent, called the supervisor psychologist a bitch, and was saying like, I don't like you, and it got really violent, verbally. Luckily not physically. Apparently he had been in the past. They had to tell me where the panic button was in case something were to happen. So that was like, how to describe it? I don't want to say at all that was fun or entertaining. That sounds very wrong. But I don't know. It was intriguing, I guess would be the best way to put it. You hear about stuff like this all the time, and it was really cool to see within those 4 patients, like right off the bat that we saw, that they were all so different. They kind of encompass different stereotypes of what I thought psychiatrists would work with. Like the first 2, they had schizophrenia, so there was a pathology to it. They were asking questions like how are you feeling on this medication? Do you like the dosage? Did you like X and X, like whatever medication better? How are the side effects? Do you feel side effects? Are you okay doing a bigger dosage? Are you taking the medication? So that was really interesting to see not only how they interacted and with their diagnosis, so being able to see someone that is schizophrenic try and describe their world to us, but then also from the psychiatrist point of view of saying, like checking on the medication and helping them in that way, as opposed to just talking out their feelings, I guess, which is the psychologist stereotype. And then to then have someone that was detoxing off of medication, which is all too common, unfortunately. So that was cool to be able to see that, someone that's cognitively intact. And then to go to then someone that's trying to work the system. Luckily this time they weren't trying to use or abuse medication and like collect it, store up and get high, whatever. But they were trying to use the system for food and a bed. So that right there, that was so cool to be able to see it. And the fact that, like, just to be able to listen to them and know that as a doctor, if I do end up becoming a psychiatrist, I hope so, I would be able to help people like that, not only with medicine, but by talking to them and asking what I can do to help them. Because the psychiatrist the whole time was asking questions like, what can the VA do for you? What can I do for you? What's your end goal? Like, where do you want to be? How are you, like, a few questions like, how are you feeling? Like, how are you feeling on this medication? How do you feel being on a medication? So that was really cool to see it, not only asking questions that you picture a normal psychologist asking, but then being a doctor and saying, hey, if there's a medical intervention we can do, let's do it. Like, let's work together and figure that out. So that was really cool to finally see what it's all about, because honestly, before today, I could not differentiate at all between psychiatrists or psychologists. But yeah, so going back to the fourth patient, he was escorted out rather quickly. And we never saw the fifth patient because while she was helping the fourth patient go to his room, she kind of just stopped by and talked to the fifth patient, who was just kind of in a cycle of abusing alcohol, drugs, yada yada, everything under the rainbow, for chronic back pain, which he was supposed to get surgery on his back to help reduce the pain, or at least make it manageable, if not get rid of it. But you have to be sober a month leading up to it, because it is so high risk that you can't have anything in your system that could compromise anesthesia, etc. But he still can't be off drugs, alcohol, etc. So that was actually, I guess, a really quick one. So she didn't. She just decided to do that on the way back, because we were talking to the fourth patient for an hour. He had a lot to say about how, I don't even know, just a lot of how he didn't have anywhere to go, and it was just like excuse after excuse. But you have to listen to him, because he does have a violent history, and you don't want to come off like you're disrespecting him, because then that happens, and it happened regardless, so whoops. But anyways, with the differences between psychiatrists and psychologists, if I can even speak, it was really cool to then, I actually did ask the attending physician later on in the day, what is the difference between the two? Obviously no, and if you guys don't know, that's fine, I will share it with you. Psychiatrists are a doctor. They have a medical degree and go through the 4 years of medical school, residency, and then a fellowship, and then get a job, that whole long track. Whereas the psychologist, you go to grad school for psychology. You take the GRE, not the MCAT. You can go to grad school for a master's or a PhD, so 2 years versus 4 years. Do research. You can do all sorts of different stuff in psychology. But there are definitely health psychologists, which are the ones that tend to work more in hospital settings. So that was the one that was in the room with us today. She would have been a health psychologist. And she wouldn't be able to prescribe medication. That's a huge difference between the two. But beyond that simple definition, I wanted to know, when it comes to actually in real life, how does it pan out? Like, are they competing for patients? Do psychiatrists truly only prescribe medication? Do psychologists get all the fun of talking with the patients? Because that was something that was concerning me within the past few days. I was kind of thinking about, like, do I actually want to do this route? You know, do I want to put in all the time to become a psychiatrist if I can do pretty much the same thing as a psychologist, or if I can do the exact same thing as both, why go through the rigor and the heartache and the stress of medical school if I can do the same thing? Sorry, that was a long loophole. But so I asked her that, and basically, well, there's a lot going on with mental health in general. What it panned down to, in hopefully the most simplified version I can give you, psychiatrists are kind of this overall umbrella within the department. They're kind of like here, if you can even see that, here. They oversee everything. So like the attending I was shadowing, she signs off on stuff. She's responsible for training. So like a nurse practitioner, a psychiatric nurse practitioner can pretty much do anything a psychiatrist can do. However, the education is different. She would have first been a nurse, then gone on to get a master's, which makes her a practitioner, and then additional training in psychiatry. So she is able to prescribe medication. She is able to basically be independent and do her own thing, have her own clients. She does, in fact, the one that's partnered with my attending, that's what I'm referring to. However, as per her job description, she has to be paired with a physician and have things signed off on and have someone you can refer to. So that, I would say that's like right here then. Like it's just below. You still have to report to someone and have things signed off on every now and then. For psychologists, they, at the VA anyways, so this can differ in different places, or at least in the VA that I was at, so not sure how widely this can be generalized. The psychologists run the group therapies, like meetings that they have in the inpatient ward where if it could focus on drug abuse, so then they lead a workshop, whatever, meeting group therapy situation on that. They also do one-on-one therapy where, you're sitting on the couch and like talking about your problems. They do more of that work that's, I think, commonly stereotyped to psychologists. So they do that. A lot of patient interaction. But again, they do not describe or prescribe. Wow. They can describe, but they do not prescribe medication. And then social workers, they're responsible for knowing the resources within their community, like different programs that are out there and open to the public, services like welfare, places where people can find financial counselors, food stamp, foster homes if you're a kid. They do more they know the system, like they know where to find different resources for you. And then the medical students, residents, and fellows are in increasing order coming closer and closer to the responsibilities of a psychiatrist. A student, you're more expected just to observe and learn and take notes. Like the M3 that I saw today, he had a notebook, a small one that fit in his coat, that he would take out, add notes, review notes of the patients, not class notes, of the patients, and would jot something down every now and then. Because it is an educational experience. That's the first time you're out in the world, you're out of the classroom doing this. Residents, they're now paid, they are graduated MD, so they get more responsibilities, or they're more like an intern. They actually do stuff, but again, the attending signs off on them. And then fellows are after residents, so it's like if you want some additional training. The residents, I guess, do 4 years in psychiatry. So you have 4 years of med school, 4 years as a resident. You are paid. It's so long to be without a paycheck, but and then fellows do get paid as well. So once you're a graduated MD, you do get paid. Because I was actually kind of wondering that, like, how am I gonna eat? But yeah, so that's how that works. So from all the things I've told you, hopefully you can kind of pick out that the attending's kind of this overall, kind of like a manager. I don't know. That doesn't really suffice, but they're the ones that sign off and are responsible for training, at least within an academic setting. Like she has a bunch of trainees, which includes the medical students, the residents, and the fellows. So kind of the head honcho. And after learning that, it made me feel better that I think psychiatry is where I want to go. I definitely am like other medical students in that we all like to be leaders. Some more than others are a little more type A and like gung-ho, want to call the shots, you know. But at least within a job setting, I think it's nice to be able to know like, hey, I've reached the max ceiling. Like I can do anything within this field. Like I can prescribe medication, I can train people, I can make decisions, I can be a consult to people and give it expert advice. You don't have to necessarily report to anyone to sign off on. You can ask for advice, of course, but you don't have to get that permission before doing something when you know that's the thing to do. So I really like that autonomy to it where, yes, I could call the shots, and knowing that there's not that like one job where it's like, darn it, I can't do that. Whereas like, like as a psychologist, like I would have to go to a psychiatrist if I thought, maybe they need medicine because they might have schizophrenia, or where they're more responsible for giving like the paper pen tests like trials or mini mental state exams, stuff like that. So I really like that. Yeah, I covered all the patients that I saw. I described the ward. Oh, okay. So then afterwards I can get into more the questions that I was asking. Well, I kind of already was. But that was the first question I had asked my attending after we had seen the patients. Questions come up and I want to know. So one of them was, what's the practical difference between psychiatrists and psychologists? One of the other questions, or actually she brought it up, the lines kind of blur nowadays, just because psychologists are fighting for, to have the right to prescribe medication. I guess New Mexico passed a law, or not, they didn't pass a law, but they had a pilot program where psychologists could come in and get pharmaceutical training, so like for the drugs and that the psychiatrists prescribe. But I guess it failed, and I'm not surprised. However, I did ask her, why, and the answer didn't shock me. So these programs, no doubt, are going to be short term, because as a psychologist, you already went through 3 or 4 years doing research and stuff in grad school. Why would you go get pharmaceutical training or drug training, whatever, if it's an additional 3 or 4 years? Like, of course it's going to be a really short blitzkrieg program. But just because you can memorize some drug names and know what they do and the side effects, that doesn't do you any good. So, like, for psychiatrists, they have been trained in the body. They've taken the science pre-med prerequisites, like biology, chemistry, OChem, physics, biochem, blah, 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 blah. And then they go to medical school and they learn more about the body, histology, pathology, a lot of stuff about the body. They can read an EKG. They know what potassium and sodium levels mean. They know what to look at within like, how is the body responding. They can look at a medical chart and know, hey, this person's levels of blank are really high. Yes, this drug would be good to treat whatever illness they have, but their body probably wouldn't respond to it. Let's try something else. Psychologists wouldn't have the training about the body unless they went to medical school, because their approach is definitely more focused on, well, like, it's a little more theoretical. Obviously, there is clinical psychology. I'm a psychology major. There is no disrespect, um, but like without the training, education, etc. that I've had with biology and that I will get in medical school, I wouldn't know how the body would respond to drugs, and that's so essential. Otherwise, you can just give, oh, I have this one drug that I give for antidepressants. Oh, I have this one for anxiety. Oh, I have this one, blah, 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 blah. No, there's a reason why multiple drugs exist per diagnosis, because everyone's body is different. There's different side effects. There's different chemicals in it. So that was actually really interesting. That was something I hadn't thought about before, and that point right there really kind of hit home for me, that this is definitely the path I want to take. I was kind of wavering. I was like, do I really want to go this route? And like, I don't want to go this route unnecessarily and then discover I'm unhappy being a psychiatrist, because I was thinking that, oh, I won't have patient interaction time. I'm just going to sign off on drugs, and if I wanted to do drugs, I would have been a, I don't know, pharmaceutical tech or something. I don't know. I would have done something like that. But today it's been really clear. You do get a lot of patient interactions, just like your primary care doctor. You have people come in, you do follow-ups, you monitor the medication, you adjust it based on what you know, how the body's reacting, and then you can call the shots as are necessary. You can sign off on things. You get to train people, which I like. I'm not a fan of teaching lecture halls, but I love one-on-one training and passing on knowledge to people that are willing to learn, which in the medical setting, you have to like learning because you're in the long haul. You're going to be constantly learning, which actually leads me to my other question. I asked, so what happens if someone comes in with a diagnosis that you're not sure about? Do you just say, I don't know, which obviously doesn't really sound that professional. So that's why I asked her, and what she said definitely resonated with me. She had said that, you know, it comes a certain point where you're mature enough to realize, hey, I don't know this. You wouldn't say it like that to the patient. She said something like, oh, so there's different possibilities, but I don't want to give you one concrete diagnosis. I still want to look into a few things. So right now there's no concrete plan, but I will get back to you and we can reform a plan. We can make a plan or something. I don't know. It was more eloquently said than that. I wish I would have remembered that, because what she said was really good and professional sounding. And then she says, so that's kind of like where the fun comes in for her. This doesn't happen a lot because obviously she's been doing this for 20-some years now outside of residency. So she got done with medical school and residency 20 years ago. So she's been doing it on her own that long, is what I'm trying to say. So that's kind of where the fun would come in, is being able to still learn something. Hey, I have this patient right here in front of me. Let's figure this out. Like, I want to know what's going on. Like, why is this going on? How is da. So she said that that's basically what the roundtable discussions are used for, where during the day she'll meet with her trainees, the medical students, the residents, the fellows, and they'll get to sit down and discuss, like, oh, hey, I don't quite know what's going on here. What do you guys think? That would more come from the trainees than her. But it's come up a few times with her where she'll present something and then they can all talk about it. But it's more common for the trainees to come up with those, and then they can sit there together and learn from it. They can look it up, and it's either a refresher or it's a new learning experience. So that's really cool. The learning's never done. I like school. I'm not scared to be in school for the next however many years, because even when I do get a real job, I'm still gonna be learning, and I think that's really cool, because I like the intellectual challenge of it. I think it's cool that every day is a little bit different and it challenges you. You're not just sitting there like I am during my current job, just copying and pasting the same stuff for 8 hours a day, 3 to 5 days a week, not thinking, just sitting. So, at least that is for me. That's torture to me. I cannot work a 9 to 5 office job. It's literally killing me. So, to me, that's really exciting. I understand this video is super long. I didn't really think it would be this long. I think I'm just a chatty Cathy. But yeah, so that was my experience shadowing a psychiatrist at the VA. She's considered now an attending because she does have trainees. She's associated with medical college, so then part of that does mean she's a part of academia, so she is responsible to train. Otherwise, in other settings, if you're not tied with a medical school, you wouldn't really have to train people as much or as commonly. Yeah, so that was my experience, and I'm really glad I had it. I was having some doubts as to whether I want to go on this path or not, especially since I will be taking the MCAT in a few months. I'll make another video soon about how I'm studying, and then my thoughts afterwards, after I take it. I don't take it for 3 more months. So, a lot going on. Glad I'm feeling more confident about where I'm going and what I'm doing. And I really hope this helps someone, or at least give you ideas about stuff you can ask your doctor that you're shadowing in different specialties. As for myself, I know this is probably one of the only specialties I'll shadow. Okay, well, have a good day.